Okay, hello everyone. My name's Ajay. I have been working very closely with Eve for about a decade now, I think, and it's been quite an amazing journey. So I'm an apprentice heart and lung surgeon, and now I'm going to be a bit naughty. Quite like giving interactive talks, and given that I'm smack bang in the middle of the day, smack bang in the middle of quite a difficult session, can everyone put their hand up? Everyone put their hand up. Yep, okay, good. Now leave your hand up. Sorry, that's wrong, but leave your hand up if you are someone living with a Fontan circulation or the parent or sibling of someone with a Fontan circulation. Okay, good. Now, keep your hands up if you know that you've had liver function tests done. Oh. Both. Yeah, good. All right. Keep your hands up if you have had a liver ultrasound. A liver ultrasound. So a scan of the liver. If you have had one. Yeah, okay. Or put your hands up if you've seen a liver specialist before. So a couple, not many. Okay. All right. What about if you've had some sort of other liver scan, like a FibroScan or a CT scan or an MRI? So a few more, okay. And what about if you've been told that you have cirrhosis? Has anyone in the room been told they've had cirrhosis? So about 4 or 5 people. Okay, all right, great. Now put your hands up if you've been in my study. All right, put your hands down. Has anyone not been in my study but wants to be in it? Okay. Good. Can you please all see one of us at the end of the talk? Good. Now, before I go on, I'd like to thank all of you because this process has made me the doctor who I am today, and I'm lucky enough to be a double doctor because this year I very proudly graduated from my PhD, which would not have been possible if it weren't for all of you. It's been a journey that began when I was a medical student, and it's consumed a lot of my life and continues to consume a lot of my life. And wouldn't have been possible at all without Eve as well. Now, it's really humbling coming to this today, and it was really humbling coming last year. I was chatting to Victoria just at the start of this session while I was hastily preparing my slides. Victoria, if you don't know, is now a doctor, a medical doctor, who is living with a Fontan. And last night we were talking at dinner about what it was like to grow up for her with a Fontan. And when she grew up, she didn't know anyone else with a Fontan. She didn't know anyone else who had had surgery for congenital heart disease. And now, I think, in part to some of the work that I've done and in large part to the amazing work that everyone else has done, we have this community. And I hope this community keeps growing, and I'm sure that it will. The research that I've done and that we do would not have been possible without a huge amount of support of funding and also the tireless work of our research assistants, who I'm sure all of you have come across. Especially today, I'd like to thank Charlotte for her amazing efforts presenting the talk. Now, before I continue, I'd like to say sorry for a few things, and it's already been talked about, but today is filled with some confronting words. You know, we talk about survival, we talk about Fontan failure, liver failure, kidney failure. We talk about transplantation. We talk about risk. And we refer to you guys as subjects or Fontan patients. And it's becoming clear to me now that not everyone likes to be talked about in that way. And I think what's more appropriate, maybe, is children and adults living with a Fontan. Unfortunately, the acronym CALWAF probably won't stick, so I think we'll scrap that. And also, I'm going to spend a very small amount of time talking about the study and talk more in general about liver and kidney disease, because I think we as a group of doctors and you as a group of children and adults living with a Fontan probably don't know very much. But I'm a bit of a pretender because I'm not a congenital cardiologist, I'm not a liver specialist, I'm not a kidney specialist, I'm not even really a real doctor, I'm just training to be a surgeon. And so it doesn't really put me in a position to say with a great deal of confidence what is the right thing and what is the wrong thing when it comes to looking at the liver and kidneys of children and adults living with a Fontan. But there are some things that we do know and there are some things that we don't know. And I'm going to try and outline them in the next couple of minutes. And I'm also going to talk about what we're currently trying to find out and what we're going to be trying to find out in the future with your immense help and support. Now, as David beautifully presented at the start, the so-called normal human circulation consists of two pumping chambers, the left heart, which pumps blood to the body, and the right heart, which pumps blood to the lungs, and they're connected. One of the main differences between the Fontan circulation and the normal biventricular circulation is that the venous pressures in a two-pump circulation are very low because blood drains from the body and then the energy gets added back in before it goes to the lungs. When you take when you take one pump out of the equation, you end up requiring higher venous pressures to drive blood from the body and into the lungs. And that results in what we in the medical world call the Fontan state. That means that there are higher venous pressures, but it also, because of the lack of the right heart to add some extra energy, means that the output of the heart is lower and it's fixed. And cardiac output we talk about in the number of litres that the heart pumps per minute. The other thing that many of you might have noticed when you go to your appointments, either with the GP or the cardiologist, you often have low blood pressure. Who has low blood pressure? Who has what's considered low blood pressure in the room? Fewer than I was expecting. So let's talk a little bit about the liver. That's where it is. It's in the right upper quadrant, assuming you don't have heterotaxia or isomerism, which some of you might have. And the liver sits at the top of the digestive system. All of the blood from the digestive organs drains via what's called the portal circulation into the liver. Now, the liver has some important functions. It's a maker and it's a breaker. So it makes proteins, it makes clotting factors, it makes hormones, it makes glucose, and it makes bile, which is really important for digestion. It also breaks down fats, it breaks down hormones, it breaks down bilirubin, which is the breakdown product of hemoglobin. And bilirubin is the stuff that makes your urine yellow, and it's what makes people with liver failure turn yellow. And it's also very important in breaking down drugs and other toxins. It's also in caviar, if anyone likes caviar. Now, the most common cause of liver damage in the community outside of the Fontan population are infections, and most notably that's viral hepatitis. And the majority of research into liver damage is in the populations with viral hepatitis. Unfortunately, all the fun things in life also seem to cause liver damage, so alcohol, pills and fatty food. But it's important to note that it's these things in excess, so too much alcohol, so more than what's considered a safe amount of alcohol, which is 2 to 3 standard drinks per day for men and 1 to 2 standard drinks per day for women. And fat, mostly in the case of those people with diabetes or who are obese or overweight, and there's a condition called non-alcoholic fatty liver disease where the liver gets replaced by fat and then starts to become scarred. Sorry, this slide's been a bit cut off, but we've known for about 70 years that another cause of liver damage and cirrhosis is heart failure. And the things about heart failure that cause liver cirrhosis are the same things that are present in the Fontan state. So high venous pressure, low blood pressure, and low cardiac output all cause scarring and damage to the cells of the liver. In this group in the room, there are some additional causes, and severe illness during infancy is now becoming a better understood cause of liver damage. And there's some small studies that have shown that even before some people get to a Fontan, they've already had a bit of liver damage. And around the time of complex heart surgery, blood pressure fluctuations occur, and that's thought to also influence liver damage in some groups. Now, liver disease represents a bit of a spectrum, and it's a pathway that's been very well described. So you start off with a normal liver, and because of some sort of injury, the liver starts to become scarred, and that's called fibrosis. Now, fibrosis can be reversible if you remove the source of the injury. With time, and that time can vary from 5 to 50 years, the fibrosis then progresses into cirrhosis, where the scarring becomes severe, or it replaces the whole liver with scar, and the amount of room left for the liver cells is completely obliterated. And it's thought that some cirrhosis can regress back to fibrosis, but once you get to cirrhosis, it's never completely reversible. And it's really at this point of cirrhosis when people start to get symptoms. Symptoms are often vague, and they're usually only very late in the disease course. And the symptoms include fatigue, easy bruising, bleeding, swelling of the abdomen because of accumulation of fluid. And these are really only the most severe cases of liver scarring and cirrhosis that exhibit these symptoms. There are also complications, and as I've mentioned, the entire gastrointestinal tract drains into the liver. And when the liver becomes scarred, the venous pressure in the veins that drain the bowel basically goes up, and that causes the veins in those organs to become damaged, and that's where some of the complications come from. But I won't go into that in much detail. Now, what about the kidney? The kidney's role is to remove excess fluid mainly. It also removes toxins, and it makes EPO, which is the stuff that elite cyclists use to dope their blood and improve their performance. And EPO is what triggers our bone marrow to produce red blood cells. It's also very important in vitamin D and bone function. And this is basically what the kidney looks like. It's got an artery that supplies it and a vein that drains it, and then it produces urine which goes out into the bladder. And the single unit of the kidney is called a nephron. So nephro is the derivative, I think, is it Greek or Latin, that describes the kidney. Kidney disease, like liver disease, represents a progression. So you start off with the normal kidney, which is a normal size. I think it's about 10 to 12 centimetres. And a normal kidney doesn't excrete any protein because the nephrons aren't sick. As the kidney becomes scarred, for a lot of the same reasons that the liver can become scarred, in the case of heart disease, that is low cardiac output and high venous pressure, the kidney starts to shrink and it starts to get rid of protein because it's sick. In most of the stages of early kidney disease, there's no symptoms. As kidney disease starts to progress, protein starts to get lost in the urine, the blood pressure goes up, and then as it progresses more, people who have kidney disease become anemic and they start to develop bone disease. And it's only really once your kidney function is less than 20% of normal that you have severe symptoms and need dialysis. And that's extremely late in the course. Now, thankfully, we now know that your population is a healthy one. You're living into adulthood, and we're focusing less on the complications related to Fontans that haven't gone so well, and more on the more subtle things like organ failure and the impacts that your health has on quality of life. But doctors are worrywarts. And the reason that we worry is that we're kind of paid to worry. You come to us so that we can worry about your health. But the other major thing to remember is that drama sells medical journals and it gets funding for research. If we went to the NHMRC and we said every person living with a Fontan's healthy, they have no problems, we're not worried about them at all, they wouldn't give us a cent to do any research. And I don't think that would be good for your health. So we need to see that there's problems. And it's emerging in the literature that there are problems with liver and kidney function. Also, we get together in conferences and we share our most dramatic stories. And we tend to come up with a picture of doom and gloom when there might not always be one. So there are many reports in the journals of those living with a Fontan who have developed fibrosis and cirrhosis. And I'm going to use another kind of confronting word, autopsy. So the majority of the series in the journals now are from series of those who have died after their Fontan, many years or not so long afterwards, who have been shown when they look at the liver under the microscope to have either fibrosis or cirrhosis. Or there are groups of patients who have had biopsies for other reasons because they have symptoms, which is the minority of those with a Fontan, and on those biopsies they've been shown to have fibrosis or cirrhosis. The other thing is that when we share our war stories, most grown-up congenital cardiologists have seen a handful of patients with cirrhosis or liver cancer, and they remember those patients very clearly. The thing that I didn't mention earlier was that once you develop cirrhosis, there is a risk of that progressing into liver cancer because the inflammation and the scarring of the liver can also trigger a process of cancer development. But actually, we have no idea of the reality of the size of the population. I'm sorry I grew up in the 90s. I like 90s movies references. But we still want to look, and it's been said repeatedly today that we as doctors, we as grown-up congenital cardiologists, paediatric cardiologists, want to pick up problems early so that things can be done about them early. The main thing that we can do about cirrhosis and liver failure is once we know that it's there, we can make sure that there's closer follow-up with a liver specialist. We can make sure that there's screening to see whether the cirrhosis progresses into cancer. The other thing about cirrhosis and liver failure is that it can make operations like Fontan conversion, which has been mentioned a couple of times today, it can make them riskier. And in certain very select circumstances, if we know someone's Fontan is not doing well and they have liver cirrhosis, there's potential to discuss the possibility of heart transplant or heart and liver transplant. But the main goal, and especially the main goal of our research, is to identify fibrosis before it gets to cirrhosis, because as I've mentioned, fibrosis is potentially reversible and cirrhosis is not. So we go and test the liver. Now, there's 3 areas of liver tests that we can do. We can look for inflammation or active damage. We can look at the function of the liver or its ability to synthesize things. And we can look at the structure of the liver or the presence of fibrosis or changes in its structure that suggest that it's sick. Inflammation and damage can be measured through blood tests. The function can be measured through blood tests or special tests where a special dye is injected that the liver processes, and we can measure the amount that's left at various time points to see how well the liver is functioning. And the structure can be measured either through imaging, through measures of stiffness, because fibrosis, the scarring, causes the liver to become stiff, or through the best way, which is biopsy. And there's some indication that there are connections between structural changes and the function of the liver, although that, as I've said, only tends to happen quite late. Unfortunately, this is where what we know progresses into what we don't really know. And most doctors, when confronted with the possibilities of how to look at the liver in someone with a Fontan, aren't entirely sure. And after looking at it for years, I'm still not entirely sure. Now, blood tests such as liver enzymes are markers of inflammation and active damage, and in most of those with a Fontan, they're normal. And even late in liver disease, they're normal. The bilirubin is usually elevated in about 1/3 of those with a Fontan, and just because it's elevated doesn't mean that the liver's sick. Albumin, which is an important protein in the blood, is also a measure of how well the liver is able to produce protein, but it can be low for other reasons in those with a Fontan, and it's not entirely a reliable marker. And finally, the INR test, which is a test of clotting function, is an indirect marker of liver function, but it's not valid if you're on warfarin, which many in the room will be. The only true way to diagnose structural changes of the liver is a liver biopsy. Has anyone here had a liver biopsy? Oh, so 3 or 4. Yeah. Was it fun? No. Would you have it again? You wouldn't have it again. Did they do it through the vein in the neck or did they do it through the skin? Skin? Did anyone have it through the vein in the neck? No. So it's a painful procedure, it's uncomfortable, it's very invasive, it has risks, especially for those who are on warfarin because they can bleed. But because doctors are worried about the problem, some centres and some groups have recommended it routinely. It can also be estimated by something called a FibroScan, which is an important part of the study that we're doing. It's a painless, quick procedure that basically uses a sound wave to measure the speed of the sound travelling through the liver, which indirectly measures liver stiffness. Ultrasound and MRI can also measure liver stiffness, but the problem with liver stiffness, especially in the Fontan, is that it's influenced by the high venous pressure. And just because the liver is more stiff in a Fontan circulation doesn't mean that there's clear fibrosis or cirrhosis. I'll skip over this, but there are also many other ways that we can measure liver structure and stiffness, and they have their pros and their cons, and there's no ideal test. In terms of kidney function, everyone will have had their creatinine measured, but it's very crude, it's very cheap, and it's very easy. Urine tests to measure the amount of albumin in the urine have been shown to be a reliable marker of kidney disease in other conditions. And then there's a special test, a nuclear medical scan, which is a part of the liver and renal study that's the best way of knowing whether there's problems with kidney function. Kidney function is not something that's been well studied in the Fontan population. And this project will really be the first to actually demonstrate the spectrum of kidney disease in those with a Fontan. All right, let's have a breath. What does this mean for those who aren't participating in research in routine follow-up? Well, we came to some consensus yesterday that a yearly blood test is not a bad idea. If the blood tests are abnormal, further imaging is a good idea, and possible referral to a liver or kidney specialist is also useful. Now, I've touched very briefly on the liver and renal study. The whole goal of the liver and renal study was to estimate the size of the population using tests that aren't invasive. Now, prevalence is the number of patients or the number of people in a population who have a disease divided by the size of the population. As I've said, it's a FibroScan, it's a test of renal function, it's a urine test as well as some other things. Before I talk about the results, it's incomplete, the results are only partly analysed, and we have no idea what normal FibroScan values of the Fontan are. Now, FibroScan values need to be validated, and they're validated for different conditions in different ways. In terms of the study, we've recruited as many people as we can living with a Fontan in Victoria, New South Wales or New Zealand, and out of approximately 250 eligible people, we've so far recruited over 100 with a plan to get 150 patients completing the study by the end of the year. In terms of disseminating the results, this was a question that was asked earlier this morning, and I think it's important to go over. If you participate in a study like this, if you don't hear from us straight away, that's good news, because we only actively contact those who have clearly abnormal results, and we arrange for follow-up for them. For the liver and renal study, at this stage, all the results except the FibroScan have been sent to the cardiologist, who's looking after you, with the plan to send the FibroScan results at the end once we understand what the whole picture is. And finally, once the study is completed and published, the results will be spread through the registry, through the website, through the Facebook page. So we've tested 108 people to date. About a quarter of them have problems with the routine blood tests that are done, which doesn't really mean much. If you choose an arbitrary cutoff of liver fibrosis of 14 as the number on the FibroScan, about 2/3 of those who participated had a high FibroScan number, but what this means we don't know yet. Thankfully, on the ultrasound, we haven't picked up anyone who had liver cancer. About 40% had some scarring on the ultrasound, and this didn't correlate with the results of the FibroScan at this stage. But I think at this stage, the most important and the most interesting finding is that kidney function seems to go down with time after the Fontan. And there's about 1/3 of those who are living with a Fontan who have at least mild kidney disease. About 1/3 of those had abnormal protein in the urine, and it seems that if you have high levels of protein in the urine, there's a stronger decrease in kidney function with time, but this is just observational, and we can't really draw any conclusions from the data at this stage, apart from trigger more research down the track. And that's it. So the study will be completed in early 2016. We need to factor in the effect of medications, especially blood pressure medications. We need to look at whether those with hypoplastic left heart syndrome had different results, and we haven't done that yet. We also need to recruit more of those who have an atriopulmonary and lateral tunnel Fontan. So if you have an atriopulmonary Fontan or know someone who does and haven't participated, please contact us. And down the track in a few years' time, I think the only way we're going to know what happens with time is for those who have participated already to come back and have another assessment. And I'd be very surprised if in a few years we don't apply for more money to do repeated measurements. Now, coming back to what you can do outside of a research situation to keep your liver and kidneys healthy. Diet and exercise for a normal weight is very important, and that's important for health in general. Consume alcohol in moderation. Don't use drugs, especially intravenous drugs that might give you hepatitis. Attend your regular follow-up appointments so that we can screen for early problems. And stay on your medications if you've been put on medications for blood pressure, and aim to reduce salt if you know that you've got high blood pressure. And really, those are the only things that we know will stop things from getting worse. Thank you very much.
We might just stop there.
Yeah,
Thank you very much.
Yeah.
Terrific. So we're just going to have 2 questions because we're going to have to jam the subsequent presentations. Yes. Ajay, would you like to answer that?
In the context of liver and kidney function, or in general?
In the context of liver and kidney function, because second over long
I honestly don't know. We'll have to look at it. We've measured hemoglobin, we've measured platelet count. We'll have to factor all those into the analysis when it's done.
Okay, any other question? Okay, right up the back there.
I just wanted to ask, with the research that has been done so far, as a parent, if we're advocating going to our doctor and say we'd like our child to have those specific blood tests, for example, do those results automatically go to the cardiologist or to the Fontan registry?
The ones that you have done by your GP, or
Yes, I mean, should we be requesting that perhaps annual blood tests be done, so through our GP initially and then cardiologist?
You have a pediatric cardiologist, you should trust your pediatric cardiologist, he's got to do a good job.
So we should talk to them about requesting the blood tests?
Yes, I think so. And these are everything points to the fact that these are slow phenomenon. So it's going to concern you after many years. It's not going to be just after a few years. I think it's going to be a few years because before you should have any concern, if you should have any concerns at all.